Hello everyone. It's a pleasure to welcome you all to the 19th IACAPAP Lunch and Learn webinar. And the topic of today's presentation is Tourette syndrome, autism, ADHD and OCD, convergence and divergence in pathogenesis and clinical presentation. This will be presented by Professor Valsamma Eapen. And hello, I'm the chairperson this evening. I'm Dr. Nick Kowalenko from Sydney, Australia. I'm IACAPAP Vice President and Oceania Coordinator, Deputy Chair of Emerging Minds, and also the Chair of the Royal Australian New Zealand College of Psychiatrists, Journalists and International Relations Committee. The speaker, as I mentioned, is Professor Valsamma Eapen. She's Professor and Chair of Infant, Child and Adolescent Psychiatry at the University of New South Wales in Sydney, Australia, and holds a number of very senior positions in research, academia, and is also chair of the Faculty of Child and Adolescent Psychiatry, the Royal Australian New Zealand College of Psychiatrists. You've got an extensive short bio that covers her many roles and positions that really are a testament to her preeminence in Australian, but also in international child psychiatry. She's also the author of Where There Is No Child Psychiatrist, which I highly recommend to you, about the importance and significance of child and mental health work, particularly in developing nations. So Valsa, I'd like you to go ahead with your presentation. Welcome, Valsa.
Thank you very much, Nick, for the introduction. And I'll be now going over, in a whirlwind, tour of Tourette syndrome and the various comorbidities that one sees in the clinical practice, and see how they come together, how they diverge, what are the unique bits and pieces, and how that might have an influence on our management. So I'm going to start with a case scenario. An young person presents with autism features for assessment. There's history of the older brother having a little bit of odd behaviors. He's being bullied at school. If you look at DSM-4 criteria, he might fit the Asperger type of symptomatology. The teacher reports about this child, says significant symptoms of ADHD. And the parents report that he always fidgets and twitches. And because of my interest in twitching and ticking, I kind of keep my alerts on to see whether he has got any tics. And lo and behold, there he is having a blinking shoulder shrug and a few tics. And I see him sniffing as well. So I've got multiple motor tics and the vocal tic, but the young boy has come for an assessment of autism. So I'm keeping that in my mind, and I start to ask about the family members, particularly keeping both those things, the autism and the other one. So the question is, if I were to give him diagnosis, he will get autism, Tourette syndrome, ADHD, OCD, if I bring out the DSM-5 and keep ticking away the criteria. But is it all part of the same underlying genes expressing itself in different clinical phenotypes among the various family members? Is the autism and Tourette's related, unrelated? Is the ADHD linked to the autism, Tourette's, neither, both? Is it shared by other members of the family, particularly the obsessive compulsive behaviors? Is it the female phenotype of the Tourette tics? So the problem is that neurodevelopmental genes haven't read the DSM criteria, so they don't expect them to kind of fall into neat pigeonholes, the man-made criteria that we have got tick, 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 and here you go, this, that, or the other diagnosis. It is the neuronal development that then decides how the neuronal circuitry is formed and consolidated, and what connections have been established and how solid they are, which is going to determine how those functional things are going to come together. So if you take Tourette's, for example, I call it a prototype for a neurodevelopmental disorder. You have multiple motor tics, one or more vocal tic, which has been there for more than a year, onset before the age of 18 years. So you don't need to have swearing to get a diagnosis of Tourette syndrome, and it is not the swearing syndrome. only a third of patients will have that. So here is Gilles de la Tourette, after whom the condition is named, but he was not the first one to describe it. His predecessor, Itard, a French neurologist, in 1825 described a French noblewoman, Marquise de Dampierre. And the story is that Gilles de la Tourette collected 8 more cases, and including the first case that was reported, he published a 9-case series, and obviously he got the eponymous fame, and the condition is now known after him. If you look at the literature from that 1885 to the 1980s, you get about case reports, but into the 1970s and 80s, a lot of cohorts started to appear. So one of the things that you now would think is 1% of children in the school age years would have criteria that would be fulfilled for a Tourette syndrome. But if I did this, is it my tic? Is it my stereotypy? Is it something else? How do you know? How do you tell a tic as a tic? One is a premonitory sensation. Usually the tic is preceded by a premonitory sensation. It could be at the site of the tic in the form of tightness or a stretch or an itch, or it could be in your head. Some kids would say it's like my brain is exploding. I have to do it. It's an urge. So in a way, that urge is something that you follow it up with the tic, and then the tic relieves the urge. That is a very significant differentiating feature. But if I did it as a mannerism or stereotypy, there is no urge, there is no relief. Another one is the waxing and waning course. They come and go, they wax and wane. And yet another feature is one type of tic gets replaced by another. No other movement disorder would do that. So if you have got Parkinsonian tremor or Huntington's chorea, it stays the same. But here you'll have a blink, a twitch, a shoulder shrug, it goes to the leg. So that site and the extent and the severity changing over the time, the waxing and the waning course, all of that would tell you that this is a tic. Stress and anxiety can make tics worse, and sometimes it gets labeled as, oh, it's not something that they do when they get stressed and it's his nervous tic. And therefore, the neurobiology of this Tourette syndrome is lost. Yes, tics get worse by stress and anxiety, but that's not the cause. The other thing that really should help you differentiate is a tic, but the opposite often happens. They can voluntarily suppress the tic. So there might be times when they would sit on it. And I have no kids who would, during the whole school period, they would sit there without any tics or hardly any, jump on the back of the car, get home, the tics kind of come out very significantly. So usually that voluntary suppression is followed by a rebound. And people would expect them to do that all the time. So, oh, he didn't have anything when he was in that situation. That means he's putting on. So all those features that I talked about should help you to decide this is a tic, but the exact opposite happens. When it changes in severity, when they can suppress it, when it waxes and wanes, all the time people say, oh, no, that can't be an involuntary tic, and therefore making it up, or it's due to stress, and all kinds of explanations come in. The next one is even worse. It's suggestible. So if you have a teacher who does a little bit of a facial grimacing, then they have to do it. And oftentimes they get caught out saying you're pulling faces at the teacher or doing things which they shouldn't be doing according to the people, of course, around you. So that suggestibility or echopraxy or wanting to imitate other people's actions, especially when you see one, you have to do one. And then when you ask about the tics, again, you have to do it. And I know parents who don't take their children to the Tourette Syndrome Association meeting thinking they'll come back with a really bad one. So that suggestibility, again, so all these features should help you to differentiate a tic as a tic.
Regular kid.
It feels weird because I'm in control of everything else. Why aren't I in control of that? Why can't I stop myself from doing that?
Like I have to go like that every single second.
I just feel like kind of funny inside. I say like, why can't I stop doing this? Why can't I stop doing this?
I had a tic, like a really loud screeching noise. All the kids would like tell me to stop and just keep staring at me. Stop it, and I would say, I can't.
Certain things trigger tics, and like, let's say reading letters, I guess. Like every time you come to the letter P, you'd have to jump like on one foot, like that.
I'm doing it so much that it drains my energy and I can't handle it and I just get tired. It's also embarrassing.
You feel like a marked man, you know? Like people would already know you when they don't.
The hardest thing is probably you can't make friends as easily as someone else who doesn't have Tourette's.
People stare. But you know what? You gotta just like let them stare.
So you saw quite a variety of tics there. So there are the simple ones like the blinking or the twitching. Of course, there are complex ones like every time when you get to the letter P that you have to do that complex jump, etc. There is kissing, licking, spitting, you name it. So there are a lot of complex tics. And the same for the vocal tics. It could be just a grunt or a throat clear to blurting out obscenities. And again, coprolalia, copropraxia, which is the involuntary swearing and involuntary obscene gesturing, occurs in only about a third. But obsessive compulsive behavior is about half of the cohort, self-injurious behaviors in about a third, ADHD in up to 75%. And no-see is another one that we need to be mindful of. It's non-obscene socially inappropriate behaviors. So it's not blurting out an obscene or a swear word, but they say something very socially inappropriate. And then immediately they will say, I'm sorry, but the damage is often done, especially if you are with other kids or with older people, etc., and they would take offense. And you're also seeing a lot of social deficits, with 5% having enough criteria to make diagnosis of autism. So in this practice review, which we did for the British Medical Journal a couple of years ago in 2022, I did it with a professor of general practice who himself has Tourette syndrome. And so it was quite a good one to do it with him, to kind of really give a personal experience there. And it's available free for downloading. And what we often say is that tics alone, or pure tics, only happen in about 10 to 13% of cases. Most of the time it comes as a package. You will have a way more of other behaviors and comorbidities. And you might ask where in the brain is Tourette's. Of course, movement disorders, we trace them back to the basal ganglia. So it's no different. Tourette syndrome has got a significant involvement of the basal ganglia structures. But depending on the site of the tics, for example, facial tics come from the failure of inhibition of the mini circuits involving the endomedian area of the caudate and the putamen. And if you remember your homunculus and your anatomy, that's exactly where it receives the topographic projections from the orofacial areas. Coprolalia, pre-post-Rolandic language areas, and the insula, and so on and so forth. Neurochemically, the three main ones are dopamine, because movement disorders come with dopamine as the main neurochemical. And I often tell my medical students, think about it as the opposite of Parkinson's. One is neurodevelopment, one is neurodegenerative. One is less dopamine, therefore you get stiff and paucity of movement. Here you've got excessive dopamine. And so you treat them with dopamine blocking drugs. Noradrenergic system, because again, we now know that ADHD, dopamine system and the noradrenergic system are important. And of course, the obsessive compulsive behaviors bring the story of the serotonin as well. And no neuropsychiatric or neurodevelopment disorders these days can escape an immune hypothesis. And for Tourette's, it comes in the form of PANDAS. Pediatric autoimmune disorder associated with streptococcal infection. Don't worry, we all know it. It's a bit like Sydenham's chorea. You have a streptococcal infection, you get choreic movements, right? Here you have got a streptococcal infection and you end up with OCD, ADHD, tics-related behaviors. And it's due to a molecular mimicry that the antibodies formed against the bacterial antigen cross-reacts with the basal ganglia antigen to form antinuclear antibodies. And what we find is that those who present with PANDAS, more often, they've got first-degree relatives with tics, ADHD, OCD, etc., which shows that it's not the primary etiology, but in a vulnerable patient who is genetically predisposed, this streptococcal infection can unmask the tics. And so we need to be very mindful of that being a condition that's going to persist even after you have treated that particular streptococcal infection. Many people also ask, is it something to do with epilepsy? Is it a myoclonus? The answer is no, there are no specific EEG abnormalities. But when you look at electromyographic activities, if I'm moving it because I want to move, then you get a buildup of the action potential or Bereshev potential in the muscles that are going to be built up. But if I do it as a tick, it's not there, which means that these movements are released from the subcortical structures without any checks or balances. And that's because you've got a deficit in pre-pulse inhibition. So in this, you can see that when you give a pulse, you get a startle response. But if you prepare them by giving a small pulse, a pre-pulse, you shouldn't normally jump too much because you're prepared. When the pulse comes, you know that you shouldn't jump because you've been prepared. But here, because of the pre-pulse inhibition deficit, you keep jumping. And that translates in the form of the sensory motor gating not effectively working and it being porous or leaky. So that premonitory urge leaks out into the conscious awareness. You complete it with the motor action, and that urge tick relief cycle kind of continues. But you can use that to your advantage in behavioral methods of treatment. That's exactly what we do in comprehensive behavioral intervention for tics. So you catch the urge, and if my urge is to move my jaw forward, that's a tic that I'm feeling the urge to do. Once I catch the urge, I immediately contract the back muscles of my neck so that I prevent myself from moving forward, or literally prevent myself from executing the tic. So the urge tic relief is broken. So that vicious cycle gets broken. And the more I break it, the more I consolidate the inhibitory circuitry to come alive. And therefore, you learn that even if you have the urge, you don't need to jump, or you don't need to complete it with a motor action. And that's the principles behind the CBIT treatment. I told you about these comorbidities. That's the main area that we wanted to discuss today. And it was part of my PhD work that obsessive compulsive behaviors are now known to be an alternative phenotypic expression. Particularly in boys and men, it comes in more in the form of tics and ADHD. But in women, in female members of the family, we see a lot more of the obsessive compulsive behaviors. So when we see highly genetically loaded OCD families, especially boys prepubertally presenting with OCD symptoms, think about Tourette story. Is it part of the Tourette family of obsessive compulsive behaviors? The reason why we need to understand that is serotonin alone may not cut it. So SSRIs may not be sufficient for the OCB, which is coming from the family of tic spectrum of behaviors. You may need to add a small dose of a dopamine blocking drug earlier in the piece than later, if you appreciate it as coming from the Tourette family. So we looked at neuroimaging-wise, what's the difference between primary OCD versus obsessive compulsive disorder occurring in the context of Tourette's. And usually primary OCD has got hyperperfusion, hypermetabolism in the basal ganglia and the orbitofrontal cortex. You get similar structures involved, but it is hypoperfusion in Tourette's. But you can't get everybody through a scanner when you're sitting in the clinic. So we looked at what would clinically, is there anything that can tell the difference? And there are some obsessive compulsive behaviors which are a telltale sign, almost give away that it is probably coming from the Tourette family. They are concern for symmetry, ordering, arranging things to the millimeter. And when they come into the room, parents will say that if I have changed slightly something, he will know. And they have to do it exactly, keep it doing until they get it just right. Only they know what's just right. They'll start doing the shoelace over and over and over again until they get it just right. And no one else can figure it out. No one else can help. They have to do it until they get it just right. So that is usually a sign of a Tourette type of obsessive compulsive behavior. Another one is forced touching. Another one is evening up. If you have something here, you have to do something there. Whereas in primary OCD, usually you get an obsessional thought, a rumination about a dirt or a germ or a contamination, and the compulsion is to neutralize the obsessional thought. So you get the difference. So one is to get it just right or to get it right, and the other is to neutralize an obsessional thought. But in the tic spectrum of behavior, you could get obsessions, compulsions, impulsions, simple tics, complex tics, and it's usually you get somewhere in the middle, somewhere along the gradient, a number of these features stacking up. Obsessive compulsive disorder can occur also in autism. right? You get lining up and you get repetitive behaviors or doing things repeatedly. How do you tell the difference? And if you ask why they are doing it, the closest explanation you get is the cognitive rigidity or getting stuck. They want it to be the same. They want it exactly the same. And that's why, or the same routine or same things or repeating the behaviors exactly the same way. And they are inflexible, being stuck. That is the closest that you would get. Whereas in a tick OCB, there will be also the waxing and the waning. All of those things changes in the type of obsessive compulsive behaviors over time. Whereas in a restricted repetitive behavior, stays the same. If they have got a rocking or whatever it is, their behavior stays the same. And the explanation is not to just get right, and it's not to avert an obsessional thought. Similarly, socially inappropriate behaviors can happen in Tourette's, can happen also in autism. Kids would say something socially inappropriate to your face without realizing that that's not appropriate. I had one kid who the mother would say that's Tourette syndrome. She couldn't take her to the shopping mall because she would say anybody who is a little bit oversized, plus size, say, she's fat. I'm sorry. She's fat. I'm sorry. So this goes on. And so she was very distressed. The girl was most distressed than mom, but that was causing immense problem. Whereas a boy with socially inappropriate behavior in the context of autism, and one mother told me that I would tell him, shh, don't say that. And he would say, isn't she fat? Am I not telling the truth? So you get the difference. One is that you don't know, but the other one is you know, but you can't help it. So it's almost like a disinhibition. And you can, again, this is in the BMJ. You can download it for free, how to differentiate the tick from the stereotypy. Most of the time, the waxing and the waning versus exactly the same thing over time. The age of onset is 6 to 7 years in ticks, whereas even before 3 years in autism and stereotypy, the stress and anxiety makes things worse. There's the waxing and the waning. You can suppress it. All of those are tick-like, whereas stereotypy, constant, same, no change, etc. Again, in part of the brains that are affected, if it is only the basic ganglia strata structures affected, you just get the tics. If it is dorsolateral prefrontal cortex involved, you get the ADHD. If you have got a failure of inhibition of the basic ganglia limbic mini circuits, then you get the OCD symptoms. So there are a number of genes that code for very specific molecules, which then goes for cellular neuronal formation, which then directs your neuronal circuitry formation. And there are a number of neurodevelopmental genes that do those different functions to help the neuronal circuitry formation. For example, here we looked at those genes who have been found to be directly disrupted in Tourette's, like neurexins, neurexin 4, IMP2L, conductin-associated protein 3, neurexin 4. And if you look at the comorbidities, ADHD, OCD, mental retardation, speech delay, mental retardation, speech delay, OCD, ADHD, autism spectrum, it's like a dog's breakfast. Where do you take this? The only commonality is that they are all neurodevelopmental genes. For example, neuroligins are cell adhesion molecules. I say it's like the cement in your building. Neurexins are synapse organizers. Leucine-rich repeats are transmembrane proteins. SHANK3 is a scaffolding protein. Whether it's a cement that's a problem or the scaffold that's a problem, the building is not right. The building is not stable, right? It's a similar way. Your neurodevelopment genes have got a very, very specific function, but they come together to form the neuronal circuitry. So different genes can end up with the same phenotype. And similarly, same gene can end up with the different phenotypes based on how the circuitry formation is impacted over time. An example here is single gene disorders. We all are easy to know. For example, phenylketonuria, single gene, you've got a very specific phenotype. But in the middle, you've got, whether it is Fragile X or Rett syndrome or tuberous sclerosis, 3 different genes, they all can present with autism as a phenotype. And in the last box, for example, Tourette genes, I should say, can present as tics, OCD, ADHD, etc. So depending on what risk genes you have collected, and the more you have a genetic loading, the higher the chances of that polygenic risk fact genes to be collected than your next door neighbor, right? So when you've collected enough and you go beyond the first threshold, we call it provisional tic disorder. Kids who have got 20% of them, developmental tics, we call it. there for a few tweaks and teachers, but disappears, doesn't last long. But when it lasts more than 1 year, that's chronic tic disorder, 1 to 2%. When you've got motor and vocal, which has been present for more than a year, that's Tourette's, it's about 1%. But those, many of them get much better with age, and by adulthood, it's much better for many. Only 0.1% will have very severe persistent ones. So based on what the initial symptom was, they may go to the if it was an eye blink or a squeezing of the eye, they go to the optometrist and ophthalmologist. If it is a cough or a grunt, they go to the ENT specialist. They may go to a psychologist if it came with a stressful factor. And they may go to a pediatrician, especially if it came following a streptococcal infection. So depending on what information or advice they get with that one, they'll go home and say, nothing to be done or no problem, right? But if you don't pick it up as the start of a tic, other tics, when they come, parents will say, that's no problem. The doctor said it's okay. So it's very, very important to keep an eye on, ask them to keep monitoring if you think that it is a tic. I already told you how to differentiate a tic from other stereotypies, etc. And then once you know that it's motor, then vocal coming up, more than a year being present, look at the family story, look at the comorbidities, and then you decide what you need to do. It may be just psychoeducation and monitoring. When you decide there is mild to moderate, you might try with a comprehensive behavioral intervention for tics or some behavioral methods of treatment. Moderate to severe, you might go with the medication. You may have a combination of the two. And if things are refractory, deep brain stimulation, etc. The question is, when do you treat? Tics when they are violent, potentially harmful, when it is associated with pain, socially stigmatizing, large attentional effort to keep yourself focused, or causing the 3Ds. Causing distress, it's causing impairment in functioning, or a significant delay or deviation from what's expected for the age and the gender, which makes them socially stigmatized or social issues come about. So in those situations is when you would treat. What do you treat with and why you would use drugs? If behavioral treatment is not available, it's too costly, they are not motivated to engage in behavioral methods of treatment, or insufficient compliance, or not responding to it. That's when you think about drugs. Again, with drugs, which one? Maybe you want a rapid effect, and you may want to look at the comorbidities to decide which medication you use. So when you've got tics and ADHD as a main comorbidity, you don't want to use stimulants as the first line. I'm not saying that you can't use stimulants. Of course, you can use stimulants if ADHD needs that and they get better with it. But you don't want to do it as the first line. You go with something that doesn't touch the dopamine system. Clonidine or guanfacine, which is a presynaptic alpha-adrenergic drug, would be the first line to go. But of course, if it's not working, you might go with dopamine blocking drugs. If ADHD is not responding, but the tics are better, you might want to try stimulants or a non-stimulant like atomoxetine. If chronic tics are associated with OCD, of course, you use the SSRI, but as I said earlier, you might want to start a small dose of dopamine blocking drug if tics are in the picture, or when there is severe aggression, rage, etc. If you've got a localized bothersome tic, sometimes botulinum toxin helps. Severe refractory tics is deep brain stimulation. And sometimes when it is waxing and waning, how do you know whether it's because of the medication that you gave or they have just gotten into a waning phase? And that's why it's very, very important through history, a direct objective examination using rating scales. A global tic severity scale, parent tic questionnaire, National Hospital Interview Schedule, which we developed. So you get a very good pattern of the number, the severity when it is in a waxing and when it is in a waning. So when you start medication, what you are looking for is to bring that steep curves a little bit down. So that's what you need to be monitoring, that even if they're having waxing and waning, whether you have brought it down, those ups and downs, that's probably that will tell you. Of course, comprehensive behavioral intervention for tics has got that awareness training, as I told you, with the competing response training, with relaxation and psychoeducation. We have looked at the impact of CBIT in neurophysiological studies, and we found that it actually increases the inhibitory mechanisms. Transcranial magnetic stimulation has been used with some positive effect, and similarly median nerve stimulation. The problem is that it doesn't give long-term effect. It may get better for a while, but then things just doesn't last that long. And because deep brain stimulation is an invasive surgery and we don't do it in children, the role of transcranial direct current stimulation has been looked at, and we found some positive signals there. Alternative medicines, meta-analysis of 47 trials of a Chinese herbal medicine found more response in the treatment group compared to the placebo group. We just finished a small pilot of cannabinoids showing some positive signals. And again, yoga, meditation, physical activity, all of those things have been trialed as alternative or adjuncts. In this slide that I have kind of said that everybody gets explanation in psychoeducation. Most people, if they have got significant comorbidities, will need appropriate treatment for that. But then the tick treatment is probably where you would be looking at picking based on the severity and based on the comorbidities. So it could be, as I said before, alpha-adrenergic drugs. It could be second-generation antipsychotics. But you need to be very careful in monitoring that, tailoring the dose. Because, for example, presynaptic alpha-adrenergic drug, the optimal level of norepinephrine will give you good activation of the alpha-2A, which is good effect. But if it is excessive levels of norepinephrine, which is what happens in fight, flight, fright, that stimulates the alpha-1 as well. That means more side effects. So each individual, you may need to kind of see what is the tailoring of the dose, doing it to the symptoms and to the side effects. Tics improve with age, and that is something that we need to be hopeful of and support them with the quality of life effects. So a lot of other effects of the tics, like the psychological, cognitive, social, school, physical, obsessional impacts. But again, quality of life means different things to different people. And so we need to see whether it's a cognitive impact, psychological impact, what is the main impact for this young person and the family, and then support them for that. Genes and the environment are always interacting. Biology is not destiny. There are a lot of opportunity to support kids, identifying them early, providing them with a comprehensive management, also keeping in mind the quality of life, because that is what's going to give them the long-term course to be advocating for themselves and for them to be feeling better. I'll leave you with this invite for next month's Melbourne International Neuropsychiatry Conference meeting. Those who are able to attend, please do come, and welcome if you would be able to make a long trip or a short trip, depending on where you are. And thank you very much.
Thank you. Thank you very much, Valsa, for that comprehensive and thorough presentation. Thank you very much for your presentation, Valsa. Very comprehensive and very thorough. And I've got a few questions in the Q&A box, which I'll go ahead and we'll put them to Valsa. But also, if there's any Q&As, any questions you'd like to ask live, please let me know. Raise your hands, and we'd be very happy to have your questions live, and Valsa will respond to them. One question is just about getting hold of the slides and ensuring that they're distributed. So, Valsa,
happy to.
Happy to. Thanks,
Happy
Valsa.
to.
And then a couple of other questions. One is about which dopamine 2 antagonist and partial antagonist, which D2 antagonist and partial antagonist, should we prescribe for tics or OCD?
Yeah. So the greatest evidence that exists in the literature is for risperidone, quickly followed by aripiprazole. So they are the main ones. And in European countries, bisulpiride here is sometimes used. And also, if you are using it as an adjunct, mainly high potency drugs, because we started with the haloperidol and the fumarate, as you would remember earlier on. And then when we moved into the second generation antipsychotics, again, it's a high potency ones that works best. So again, risperidone, aripiprazole.
Thanks, Valsa. And a similar question, can you give us some examples of dopamine blocking drugs?
So they were the dopamine blocking drugs that, just said either From the first generation, we used to use the haloperidol pimoside, but now it is mainly risperidone and aripiprazole.
And one question, why is this considered a psychiatric disorder rather than a neurological one?
Okay. It's interesting you say that, because ICD has just done that. They have moved it to neurological disorders. The reason why it has been in our space, I mean, it's a mixed thing, in different parts, depending on, it could be a pediatric neurologist, a neurologist, it could be a psychiatrist, etc. The reason why we have had something to do is, one, the medication that we use, we know more about, more than the neurologists, because they are dopamine blocking drugs, right? And the comorbidities are again our space, right? Whether it is OCD or ADHD, it's us rather than the neurologist. So although it is a movement disorder, because the medication that's used belongs to us and we have got more experience, and the comorbidities also we have got more experience with, it seemed to be a better bet for us to be dealing with it. But depending on which country, which part of the world you are in, it's managed by different professionals.
Thanks, Val. Another question, with irregular and unreliable supply of this wide range of drugs, particularly an example where it might be that clonidine has had to stop because of availability, without other options available in the market, do you suggest any specific pharmacological interventions in these cases where there's a lack of available drugs that have more evidence?
So as I was saying, the presynaptic alpha 2 adrenergic drugs, the clonidine, and sometimes in some countries, guanfacine is available. If you have risperidone, aripiprazole, etc., then that's one group of drugs. Sometimes in some developing countries, you may not have any of that in continuous supply, or you may get into trouble. And most of the time, I have found that haloperidol is one that is available in most places, and you can get hold of it in a more reliable, consistent way. And then, that's what you use. Yeah.
Thanks, Valsa. And a letter. Whoops, I just had a question which has just moved on here. Do you think stimulants aggravate tics or precipitate them? Can stimulants make tics more difficult to treat?
Okay, so it's basically, it's not a contraindication, although you need to carefully monitor. That's because stimulants do their job by releasing dopamine and all the catecholamines, and dopamine is an important one that it releases. Of course, as we know, when you release dopamine more into the system, because tics can get worse. But for some children and adults, it's of no consequence, so it doesn't particularly matter. For some others, initially when you start, there is that kind of emergence of tics or unmasking of tics, or what you said as the precipitating the tics, never causing it, but it would have come out at another time, but this has kind of made it come out at that time. You need to kind of see whether it wears off, because you kind of, you have got a shock in the system because of the more release of the dopamine. But if it stabilizes and it isn't going to do any harm, you can monitor it. But if it's continuing to persist, the tics are becoming worse, of course, then you've tried it, but then you have to either add a dopamine blocking drug if the ADHD is helped, but the tics are getting worse, or if neither are getting worse and it is just a matter of side effects only, then you move on. You just kind of stop and move on to other medications. Yeah.
Thanks again, Elsa. Is there a role for GABA from an inhibitory point of view?
Yeah. I mean, GABA is not one of the primary chemicals that are involved in movement disorders. Yeah? So sometimes gabapentin is used, and sometimes anti-epileptics, there is topiramate is used, lamotrigine has been used, but they are not the kind of the primary drivers for movements, and therefore, second and third line, if you like. and if the other ones are not tolerated or you need another reason why. But there are a number of them. I told you that you can download the practice review in the BMJ. It has got a lot more details about that. The slide that I showed, but I couldn't go through all of it. It has got all the other medications that I used as well. Yeah.
Thanks very much, Valsamma. Can you comment on using Ozempic for treatment-resistant tics?
In case reports, yes, but not in big studies that we know the evidence to be saying one way or the other. Yeah.
Okay, look, thank you very much, Valsa, and thank you for your questions are coming in very thick and fast now. There are many more coming in, so thank you for your very keen interest, and I'm sure that's a product of your very interesting and comprehensive account, Valsa, and your excellent presentation, so thank you. I do want to mention that an e-certificate of participation will be provided to those IACAPAP members who have attended this webinar once you've completed the survey at the end of the webinar. The survey will be displayed in the browser, and only after the webinar has been completed, and it's also the pathway for this you to secure your e-certificate of participation. Look, thank you very much for your very active participation. I want to thank Valsa again for covering an enormous amount of work and doing it so clearly and comprehensively, and for managing to cover it in such a short period of time. So thank you very much, Valsa, for your presentation. I want to thank IACAPAP and thank you, Sue Wong, for supporting this presentation and ensuring it's all works so smoothly. Thank you, everyone, and go ahead and have a great day. I look forward to receiving copies of the PowerPoint slides, and thank you again, Valsa. Oh, there'll be a presentation coming out the 20th. The IACAPAP presentation, Lunch and Learn webinar will be following on about November 20, and will be a presentation on digital interventions in child mental health. Thank you, everyone.
Thank you.
Thanks, Valsa.